Welcome to the Assessment Lecture for the Paramedic Prep course. My name is Nathan Klein, and we will be looking at what it takes to perform a good assessment on a patient in a pre-hospital setting. First, I want to explain to you what a good assessment and what a good assessment can do for you as a emergency care professional. Why is it important to obtain a good assessment for our patients? Well, first off, patients don't always know what it is we want to know. If we could walk up to a patient and they gave us a complete and accurate rundown of the situation, then assessments may not be necessary. But unfortunately, that isn't the case. They may not know what information is important, or they may overvalue information that to us isn't very useful. That's why we must direct patients to provide the most useful information. Secondly, what treatments we provide to the patients are based on facts of the incident. We do not do random things for no apparent reason. We should always have a strong justification for all of our actions on a scene. Those justifications come from a balance of subjective and objective information that is collected from the scene. To be clear, in medicine, subjective information is that which is told to us by others, while objective information is what we see, hear, and feel, etc. This, of course, means that good assessments will lead to good treatments. And that is really our goal when it comes to treating our patients and doing our best to help them. So let's look at what is considered the standard format for assessments in the pre-hospital setting. This is the National Registry Medical Assessment Skills Sheet. There are copies of this in your Canvas module. There's also similar ones for the trauma assessment. What this provides for us is a standard structure for the task of assessment. I'm not expecting this to be a comprehensive guide to assessment. This is more like a skeleton on which we can hang the additional layers of assessment. You might think that if it isn't enough, then why use it? The answer to that is that it gives us a great starting point for new and returning EMS professionals to build their assessment skills from. Let's look at the individual sections of an assessment, and we'll discuss the various aspects of it. So first is the scene size up. These are the things we want to think and make decisions about as we are arriving and approaching a scene. So we're going to start with our personal protective equipment. This is going to be like our gloves, our masks, our gowns, the things that are going to protect us from body substances, from blood, vomit, and mucus. And this is going to be something that we're going to be assessing throughout the scene. As information is given to us, we may determine that additional PPE is necessary. The next part of that is scene safety. We need to make sure that we're protecting ourselves and our partners from the dangers that are on scene. There are many things that can cause a scene to become unsafe. Animals, people, the patient themselves, machinery, cars, toxic gases, chemicals. All these things are something that we need to be aware of. And when the scene becomes unsafe, we need to remove ourselves to protect ourselves and to be able to best serve our patients. If we ourselves become victims, then it's impossible for us to help our patients. Another piece of information we can obtain is the mechanism of injury or nature of illness. This is normally provided by dispatch to give us some early indication of what we'll be dealing with. The next part of that is the number of patients. Do we have a patient count? And this is important in conjunction with our mechanism of injury for the next section, which is going to be additional assistance. Do we need more ambulances or more fire trucks because there are more patients? Or do we need specialized rescuers such as swift water rescue or hazmat or narrow angle rescue to come out and assist us? So finally, we need to think about spinal immobilization, spinal stabilization. So when we're arriving on scene, we may need to bring ourselves some backboards, some C-collars, and the other equipment that may be necessary if we consider the possibility of spinal immobilization. With that, we're going to move up into our primary survey. This is going to be our initial, as we're arriving on scene, our initial look at some of the life threats and hopefully being able to intervene in those before they become too critical. The first part of that is going to be getting a general impression of the patient. This is when we walk up, what do we see? How is the patient sitting? How are they? What's the area around them look like? We want to look for clues that might lead us to what's going on with this patient. Once we make patient contact, we want to determine their level of consciousness. In the written portion of this module, I went over a memory aid or mnemonic of AVPU, which stands for alert, verbal, painful, and unconscious. This correlates to the actions that were necessary for you to elicit some response from the patient. After we determine the patient's level of consciousness, we need to determine the patient's chief complaint. The chief complaint is the reason that the emergency services were responded. This could be explicitly stated by the patient, such as when they say, "My chest hurts," or implied, as is the case when a patient is found altered or unresponsive on scene. Once we have started our assessment and obtained a chief complaint, we need to quickly assess what is called the ABCs. This is the major life threats that need to be addressed immediately upon discovery. First aspect of the ABCs is the airway. We need to determine if the airway is open and free of obstructions. We use a term called patent, which means open. One way we can assess this is by opening the patient's mouth and directly visualizing the open airway for possible obstructions. The most common airway obstruction is the patient's own tongue. This obstruction can be corrected by a simple repositioning of the head or a jaw thrust maneuver. Another way to assess the airway is if the patient is speaking to us. We can deduce that a patient's airway is clear if a patient is able to speak to us. The B in ABCs stands for breathing and is the next part of our primary survey. We need to assess if our patient is breathing adequately, and if not, provide ventilatory assistance. We should be assessing our patient's respiratory rate and quality. If our patient is breathing often enough, but is having difficulty breathing, then supplemental oxygen is indicated. Speaking with the patient and listening to lung sounds can supplement direct visualization when determining the need for additional respiratory assistance. The final part of the ABCs is circulation. Here we want to feel the patient's pulse. Is it fast or slow? Regular or irregular? Strong or weak? We will also want to take note of the patient's skin signs and determine the relative temperature, color, and moisture, as abnormal findings can be an indication of shock. The last aspect of circulation is looking for and treating any life-threatening bleeding. This can be accomplished with either direct pressure or the use of a tourniquet. When assessing the ABCs, we must prioritize our response to any abnormalities. These three aspects of the primary survey are here because they represent the major life threats to our patient and therefore warrant the most scrutiny and aggressive intervention. Once we have assessed and corrected any life threats to the patient's airway, breathing, or circulation, we can make a determination about how and when we will transport our patient. If we determine that the patient is critical, then we will want to forego any unnecessary assessment or intervention until we have initiated transport. Once en route, we can continue our assessment or treatment of the patient without delaying definitive care. One example of this is not splinting an extremity injury on scene because the patient is showing signs of internal life-threatening hemorrhaging. On the other hand, it bears reminding that we should not delay intervention that relates to airway, breathing, or circulation, as these are life-threatening. An example here is when a patient is found to be in cardiac arrest. While transporting to the hospital would be nice, the priority should be to providing CPR to the patient and is often best accomplished by staying on scene. So once we have completed our primary survey, we're going to get into the secondary survey. This is a whole series of questions, and I always like to think of it like a branching tree that starts off with the trunk of the chief complaint and then moves out along these branches. And while there's so many questions and we cannot go over all the things that you could ask a patient on any scene, we can talk about some of the major trunks that come off of the main tree. And we like to use mnemonics or memory aids for those. We have here, as we're moving down into the subjective assessment, this is going to be the things that people tell us that are advised to us on scene. And we use mnemonics OPQRST and sample. Let's take a look at a few of these. First of all, OPQRST is about the complaint itself. It works best for pain, but it really can be used for just about anything. O in this mnemonic stands for onset. We want to ask the patient questions to determine if the complaint came on suddenly or gradually, and has it been constant or does it come and go? P is going to be our provocation. Does anything make this complaint better or worse? In the case of pain, If we palpate, does that make it better? Does movement make it worse? Those are some examples of what we're talking about. The next branch in our tree is quality. Here, we want our patient to tell us what their complaint feels like. This is usually assessed with some sort of open-ended question like, how would you describe your pain? Some common answers are sharp, dull, burning, squeezing, etc. Next is radiation. Does this pain move anywhere else? Does it start somewhere and then move to another part of the body? A classic example would be patients who have pain in their chest and it radiates down their arm or up in their neck. This is a classic example of a myocardial infarction. Next, we want to get a severity. This is important for, especially if we're going to be doing interventions that may change their pain level or the severity of the complaint. If we get a baseline, then we can compare and contrast if the intervention we performed has had a positive effect on the patient. This is commonly, in the case of pain, used to, in an example, on a scale of 1 to 10, 10 being the worst pain you've ever felt, how bad is your pain? And so the patient would then give you a number. Then later on, after you've produced or performed a intervention, we can then ask that question again and get a different number and see if the pain has gone up or gone down or stayed the same. Finally, we're going to talk about time. This is going to be how long the pain has been or the complaint has been going on. Has it been going on minutes, hours, days, weeks, years, in fact? That is how we use OPQRST to remind ourselves of some basic questions we can ask about our patient's complaint. Another mnemonic we can use is sample. With sample, we will gather more information about the complaint, as well as obtain some history to put the complaint into context. S stands for signs and symptoms. Signs are things we can see, while symptoms are things that the patient tells us. This can include information that the patient already has told us, like the chief complaint, or it can be additional information like other abnormalities or related complaints. An example of this would be someone with abdominal pain. We might ask them about any recent nausea or vomiting, as well as any issues with their bowel movements. Another example would be to ask about shortness of breath or dizziness when a patient is complaining of chest pain. The human body is an interconnected system, so we need to investigate related systems outside the chief complaint in order to assist with our field impression. The A reminds us to ask about any food or medication allergies. This can be very important if we are planning on giving the patient any medications and want to avoid making their condition worse by inadvertently causing an allergic reaction. It can also be important if we suspect our patient is having a reaction to something that they were recently exposed to. The next part is medicine. With medications, we want to see what medications they're taking. This can be helpful for determining their past medical history, but also it can help us rule out possible interactions with either things they've taken before or things that we're going to give them afterwards. Past medical history is that next part where we're going to ask them about any surgeries, any past medical procedures, any diagnoses that they've had in the past. This can help contextualize some of our signs and symptoms. One example of how that can work is if someone is having signs and symptoms that are similar to a condition they've had in the past, that can help us determine what possible causes for their signs and symptoms today. The last oral intake. This is going to be what's the last thing they ate or drank. And this is important not only for us in contextualizing our signs and symptoms again, but also for the hospital. If they're going to go into surgery, they're going to want to know when the last time this person had anything to eat or drink. This can also include things besides food and water, such as alcohol, drug ingestion, things like that, which can help establish a possible cause for the signs and symptoms. And finally, the events. If this, even though we sometimes get this information during our assessment, we want to make sure that we are asking about the events. What led up to this? What was immediately going on prior to this onset of these symptoms? So at that point, we sort of have the basis, the structure for our subjective assessment. We want to move on to an objective assessment. And as we discussed earlier, objective information is things that we ourselves observe. And by doing that, we're doing ourselves a head-to-toe assessment of this patient. Now, while we want to look head to toe all the time, we want to focus especially on the affected areas. If a person is complaining of pain to their arm, then we want to make sure that we're making an asserted effort to look at their arm and look for possible injuries in that site. Chest pain, we want to make sure we're looking at the chest, and this may involve exposing the patient's skin to be able to look at the body, but also making sure that we're keeping the person covered for modesty and for warmth. But when we're looking at the patient, not only are we going to palpate and ask them some subjective questions while we're doing that, but we're going to look objectively for the following things. And again, we have another mnemonic, and that is DCAP BTLS. And that's going to remind us to look for the following: D for deformities. When you see a bone and the bone isn't shaped the way that it should be, that's a deformity. This could be a sign of a fracture. It might be important to ask the patient subjectively, was this prior to the incident, or is this something new? Because patients sometimes will have deformities from a previous incident, perhaps, especially if they didn't have a bone set properly and it healed in a weird position. Next would be contusions. This would be bruising. So any bruising that you might see could be a sign of some internal trauma, internal hemorrhaging. So that's important to look for contusions. Abrasions. This is going to be those superficial lacerations across a wide area of skin. Abrasions can happen from rubbing up against something rough. For example, motorcycle accidents, they'll often have abrasions from rubbing against the pavement, but you can get abrasions from all kinds of things. We want to look for those and be able to treat them accordingly. Punctures, again, going deeper into the skin with a single object. Punctures could be knife wounds, bullets, impalements from various objects. We want to look for punctures. This is especially important when looking that we look at the entire body, because in the case of gunshot wounds, people can be shot and not realize that they've been shot in an area. We can sometimes miss a puncture that could be vital to that patient's care. So we want to make sure that we're looking for punctures wherever we are exposing the patient. Burns, these are kind of like abrasions, but they're caused by thermal or chemical means. And so we want to look for burns and treat those accordingly. Tenderness, when we're palpating this patient's body, that we want to see if there's any pain on palpation. They can tell us if they're pain, but you can also see if this person is wincing. They kind of withdraw, tense up. That can be a sign of tenderness. Lacerations, we want to look for those, and if they are bleeding profusely, we want to make sure we're controlling that bleeding. And finally, swelling. This can be a sign of internal bleeding. This can also be just a sign of injury. Swelling is a common reaction our body has to injuries of various kinds. But identifying those are really important. So this is our DCAP BTLS, our head to toe. At that point, we finished with our subjective and our objective assessments. We want to get some factual data about this patient's body systems, and that we call vital signs. So as we move down the tree, we're going to get to the vital signs. We're going to go over three major ones, but obviously there's lots of different kinds of vital signs you can do. You can check pupil reaction, skin signs. Some of these things we've already done during our primary assessment, but we want to make sure that we're hitting them if we haven't already. So the first thing is blood pressure. This is where we get the cuff and we take the stethoscope and we obtain a systolic and a diastolic blood pressure. Basically, the systolic being the pressure of the blood during the heartbeat, and the diastolic on the pressure of the blood during the heart while the heart's at rest. So we can also sometimes get a palpated blood pressure. This is where you're pumping up the cuff, but you're only feeling for a pulse. And this can give us a systolic blood pressure, which is great for obtaining a fast blood pressure, but it's not going to give us the full picture. So we want to make sure that we get a good blood pressure at some point during the care of the patient. Next, we want to make sure that we're getting our pulses. This is not just like in our primary survey where we're just feeling, is it fast, is it slow, is it regular, is it irregular, is it strong, is it weak? But we want to actually get an actual minute amount for the pulse. This can be obtained by feeling the pulse for 15 seconds, timesing it by 4. That's a real common method for obtaining a 1 minute long pulse rate. We want to do the same thing for our respiratory rate. We can get a minute rate for that. Some people often will take a smaller sample, such as taking a 6 second and timesing it by 10. Is a little bit faster, less accurate, but will give you a ballpark figure for the respiratory rate. We also want to look at their quality. Are they having any sort of difficulty breathing? Are they tripoding? Do they look like they're in distress? We want to listen to our lung sounds if we haven't already. So as we move through our vital signs, we want to move on to our wrap up. This is where, now that we've performed our assessment, we're going to first make a field impression. This is, what do we think is going on with this patient? And this is important that we establish what's going on with or what we think is going on with this patient, because right after our field impression, we're going to want to then perform interventions. And as I said at the beginning, we don't do random things for random reasons. We justify our actions. And in this case, our interventions are justified by our field impression, which is justified by our subjective and objective assessments. So with our interventions, these could be oral glucose, aspirin, nitro. In our medications, on our medications day, you're going to go over all the medications you could give. This could be other procedures like splinting, bandaging of non-life-threatening injuries. But we want to, after creating our field impression, then perform any of those interventions that we have not already. This wouldn't include things that are life-threatening, such as ventilation, supplemental oxygen, because we've already performed those during our primary survey. Next, we want to do a reassessment. We've done some interventions. We've hopefully changed the patient's outcome, and now we want to see how has that affected the patient. Has it affected them positively or negatively? And we want to reassess the patient's body systems. We want to reassess the patient's vital signs. Basically, we're going to start back at the top with the primary survey and continue down. And how often do we do this? Well, the standard care is that in a non-critical patient, you want to reassess at least every 15 minutes. With a critical patient, we want to assess at least every 5 minutes. Remember, I said at least, so you can reassess more often. And you will find that you are generally reassessing constantly to some degree or another during your time with your patient. And finally, we want to give a good report. This report could be to a higher level of care on scene. This could be a radio report to a hospital that you're en route to. This could also be to the doctors or nurses at the hospital when you hand over care. But we want to be able to coalesce the whole scene and all of our findings into a nice package to provide them with some context in which they can start their own assessment. So being able to wrap up everything within a nice story and to be able to give them a rundown of what's going on with the patient, what you found, what your conclusions were, and what you did for this patient, and what was the outcome. And that's really important for the report. So at this point, that's an assessment. I want you guys to go back to the module. If you haven't already, read the introduction, which is a great, more in-depth rundown about assessments. And I want you to watch some of our sample assessment videos. They're done by some great people, and they give you a really good example of what we're expecting when you come in for your skills day. And we want you to improve your assessments and hopefully improve your care for your patients in the field. I want to thank you so much for listening to this lecture. If you have any questions, please put them in the discussion. And I appreciate you, and I will talk to you later. Bye-bye.